good to go. Right, everyone, we're going to start back now. Okay, so welcome along to any new members of the public who have joined us. So the next presentation, which will be a 90-minute presentation and then 30 minutes allowed for any questions, is from the Waikato DHB, and there are a number of people here today for the DHB, and I welcome all of you and thank you very much for joining us, and I do acknowledge your CEO, Craig, and welcome along, Craig. So the same sort of format, you're all up here and just the speakers and your order and whatever way you wish to present, just continue on and come up, and our staff will assist you with any computer or presentation issues that need to be happening. And when it comes time for question time, if you can all remain there, that would be helpful, so that then the councillors can direct any questions to anyone there. And we've been finding the microphones, I think, very useful, so that people down the back can hear. So if you can make sure that you stand near the microphones when you're speaking, so that we can pick it all up. And there are a number of people recording and filming these proceedings, just to let you know, and there are media in the room as well, so thank you for that. All right, so DHB, first speaker, welcome along.
Thank you, good morning. I'm Craig Climo, Chief Executive of Waikato District Health Board. I assume we would have an overhead display.
It was just taken down to get it.
Ah. Thank you. That's a list of our team here today, and I'm not going to go through and introduce each of them in the interest of time. And our other speakers will introduce themselves as they speak. But worth making an observation that it's quite a sizable team, and it's a heavyweight team, which reflects the importance of this matter to both the District Health Board and nationally. I'm just going to very briefly frame fluoridation around financials. So the cost of oral health care per year to the District Health Board is, as you can see on the overhead, about $5 million in terms of Hamilton residents, and about $16 million across the whole of the Waikato District Health Board area. And of course there is an unknown quantum of private costs, which we have no ability to try and estimate. And when I say private costs, the cost of dental care through dental decay. Based on a predicted increase in tooth decay of about 10% if the fluoridated water supply is removed, we estimate, or I estimate, that would have an extra cost of about $500,000 per annum ultimately for the District Health Board, and with, of course, also adding the comment that all of the District Health Board's funds are spent, which means that any increased cost has to come out of health services somewhere else. So thank you for listening to me. That was very brief, and I'll hand over to our next speaker.
Kia ora koutou katoa. Ko Rudy Johnson aho. My name is Rudy, and I am the tūmaki and current chair of Te Ao Marama, the New Zealand Māori Dental Association. We are the Māori oral health workforce, and we're passionate about our work, and we advocate for good oral health outcomes for Māori wherever we can. For me, it's a privilege to be here on behalf of my organisation, and also as a dentist myself, I'm proud to come and support the kōrero here today for retaining fluoride levels in the water supplies here in Hamilton. Firstly, I'd like to acknowledge the Mayor and councillors here today. I appreciate that this decision-making role is not an easy one for you regarding water fluoridation, but please don't take it lightly. For Māori living in your area, this is a very important decision, and I'll briefly outline why for you today. Secondly, I'd like to acknowledge Albert Kiwene. He's just sitting over here to my right. He's an esteemed member of our organisation. He also graduated as the first Māori dental specialist, and he'll be presenting shortly on his clinical insights and experiences whilst working here in the Waikato for more than 40 years. I'd also like to acknowledge Waikato DHB for standing up and taking the lead role in this very important kōrero, and also for gathering this very well-known and knowledgeable group of presenters. We're all here to say the same thing today, which is please retain the status quo and maintain the adjustment of fluoride levels in your water supplies. Today I've named my presentation He Oranga Niho Mo Te Iwi Māori. This is the kaupapa or the goal of Te Ao Marama. This is what we strive for. It means good oral health for Māori for life. For life means from young pepe to our aora Māori or kaumātua. So this is who we are, and our members strongly support community water fluoridation and endorse the adjustment of fluoride in drinking water supplies to optimal levels, mainly to help reduce tooth decay. So why do we support community water fluoridation? Well, the decision is easy for us. Firstly, it supports our kaupapa. For Māori, having good oral health is all about being able to eat and speak properly. It's about being able to hongi, kiss, smile and laugh with our whānau without feeling uncomfortable or embarrassed. It also means being free from oral diseases like tooth decay. All of these things contribute to good overall health and well-being too. Secondly, community water fluoridation is free, accessible and readily available to the whole whānau. Fluoride bathes the teeth and protects them from tooth decay. For Māori adults, this is important because they are less likely to access dental care and are more likely to be left with unmet need. It is also crucial for our tamariki and our rangatahi. They have worse oral health than non-Māori kids and adolescents. To see where we're coming from, health for Māori can be represented or can be explained using te whare tapawhā. And basically in this picture it shows that with strong foundations and four sides, a house can stand proud, an individual can stand proud and a whānau can stand proud. The sides represent the four dimensions of Māori well-being. So for Māori it's not just about our tinana, our physical health, it's also about our wairua, our spiritual dimension, our whānau, the role of our family, and our hinengaro, which is the balance of our mind. However, should one of these dimensions be missing or damaged in some way, a person or a whole whānau can become unwell. In oral health, four key aspects fit nicely into this model: limiting sugary foods and drinks, having regular dental checkups, brushing twice a day with a fluoride toothpaste, and drinking fluoridated water. However, in Aotearoa, the opportunity for good oral health and access to dental care, healthy kai, toothbrushes and toothpaste, and community water fluoridation is not equally available to all, especially Māori. We know that health within a population, it does vary for a number of reasons, and health needs differ between individuals and groups. Martin Luther King said that these reasons are unjust, even shocking and inhumane when the differences are based on opportunity and access to appropriate resources. Both the recent 2009 New Zealand Oral Health Survey and 2011 and 12 New Zealand Health Survey confirmed that Māori are at greater risk of poorer oral health, especially having low incomes and limited access to dental care. Also, the ill effects are found to be most dramatic between children living in non-fluoridated in fluoridated areas, particularly for Māori, where the gap is widening. Community water fluoridation continues to help close the gaps in health coverage, which is a prerequisite for eliminating inequalities in oral health, in health care and oral health status. Lastly, we must also remember that for Māori, water has special significance. This has been recognised in government policy, but the main point here is that Māori always need to be consulted to make sure that our values and concepts are taken into account in the decision-making process. For Māori, water fluoridation brings good oral health and well-being and protects our people's teeth. Also, there is no conflict with the concept of obtaining pure water for special purposes. Being Māori, wherever you live in Aotearoa, you know where to go to find these sacred sites to get water for special purposes, thus rendering fluoridated and even chlorinated water a non-issue here. In closing, I'd like to remind you of the kaupapa of Te Ao Marama, the New Zealand Māori Dental Association. Hei oranga niho mo te iwi Māori, good oral health for all Māori for life. We support community water fluoridation because it supports our kaupapa, it's available to the whole whānau, it fits into our concept of health, and it has no conflict with our concept of waiora or pure water. So I encourage you to make the decision to retain the current adjustment of fluoride levels in the water supplies here in the Hamilton area. Aku mihi nui ki a koe. Tēnā koutou, tēnā koutou, tēnā koutou katoa.
Kia ora koutou, nau mai mihi mai. Ko Albert Takoingo no Kawhia ahau. Greetings to you all. I live at Kawhia, the town by the sea. I acknowledge the Mayor and members of the council and the DHB who are here. I'm grateful to have been given the opportunity to support the retention of fluoridated water in this Hamilton City, also the wider Waikato area. As I said, I come from Kawhia. I've been there. My father was born there. My family are deeply rooted there in land and other interests. I also know too that there are a lot of young Māori children who have suffered from severe decay because of the fact that the water isn't fluoridated. There may be other reasons, but there is one thing that we can control, and that is to have fluoridated water. So I would like to mention that I have worked in general dentistry for some years in these places: Rotorua, Tauranga, Tokarua, Thames, Raglan, Hamilton and Auckland. Why is that? Because I had many branch practices as a periodontist. I also was employed by the Waikato Hospital Board as a visiting dental consultant and as a founding member of the Association of Te Ao Marama. And I've worked and lived in Hamilton for many years. And so I was here prior to the introduction of fluoride in the water. I know what it was like then. I know what it is like now. There is a big, huge difference. What has made the difference? I would propose that it has been the introduction of fluoride in our water, because it gets access to those who really need it, and that's everybody. If someone doesn't want it, maybe they can have the filter. I know for our Māori people whose economic situation may not be so great, then the best way for them to get the advantage of fluoridated water is by it being in the local water supply. Speaking for our children, our tamariki, they need fluoride more than they need dentists. Their health is a taonga. guaranteeing them good health under the Treaty of Waitangi. I am frequently asked, Matua, what do you think of fluoride? Is it safe? My answer has been always absolutely. I wouldn't have given fluoride tablets to my own children prior to the days of fluoride. If it's good enough for me, it's probably good enough for you. I would say to them also, why don't you have a look at Hastings if they had any queries. Hastings has had fluoridated water for some 60 years, I believe. Now, has there been a lineup of ambulances to the hospital? I believe there hasn't been. In fact, they've closed that hospital. If fluoride is not in the water, then Maori will suffer. At the right dose, it is not a poison, I believe. It is a therapeutic agent. My experiences at Waikato Hospital saw me remove from young children's mouths all their deciduous teeth because of decay. Many of those children under the age of 5, having to give them a general anaesthetic. Mostly Māori, and most of them from out of Hamilton, believe it. I also follow the kaupapa of the New Zealand Māori Association, an association we as Māori are able to put our own cultural understandings into the things that matter the most to us, and fluoride is one of those. And so today, after 40 years of fluoride in our water, my clinical examinations of current young people today, and in the past few weeks, has seen me find less tooth decay. Prior to the introduction of fluoride in the water, we as dentists were able to examine every 6 months, take x-rays every 6 months. Why was that? Because the demand was there, the need was there. And on every child you would find a DMF figure that's missing decayed and filled teeth, probably over 10. Today, a lot of it is 0 or 1. I was at a school that was a boarding school, examining a lot of students, and the DMFs were, as I say, 1, 0. And then suddenly, in the chair, I found this youngster who had something like about 10 to 15. And I said, hey boy, I bet you're not from Hamilton. Where are you from? Punaruku, sir. They say, they are as clear as anything. Punaruku, if you don't know, is way up north. And I went to school up north, so I don't want to cast a slur on the place. I love it. It's a great place. But we see it, it's so clear. I commenced practice, as I said, and they were the days when I used to see something like 30 to 45 patients a day. Today, most dentists probably see 12 to 15. See a patient every 15 minutes. Why is that possible? Because the need was there, and a lot of the patients didn't need anaesthetic. It just depended on the age of the patient often, but that was a lot of work. A lot of work was done under general anaesthetic. It was either drill them, fill them, or take them out and place dentures. And hence I headed back to university because I thought that there was a better way of doing dentistry, not able to practice what I was taught, and that was to diagnose and to provide the best treatment. The best treatment in those days was really dictated by the huge demand, the finance that people could afford. You see, fluoride hardens the enamel, I believe. A little bit of the science I do understand. It might mean today that we have to look harder, that we have to determine that caries is there. And so we practice minimum intervention. We take x-rays so that we can see, because the decay may be under the enamel. In the early days, prior to fluoride, you didn't have to do that so much because the enamel was weak, and so it broke down and you could see a big hole. People came to you because they suffered pain. They had obvious holes in their teeth. And so you filled them. No wonder we were called often the murder house. And today, young folk enjoy coming to a practice where I can see 50 to 60 people and not find more than 2 or 3 fillings. I had an experience one day of a mother who lived out of town, out of Hamilton. I had a practice over in Glenview, and she brought her 3 daughters, and I examined them and I was amazed. Not one of them had caries. And she said, "How is it? How are my children's teeth? How are the girls' teeth?" I said, "I can't find a filling. You're one of the few in my practice that I don't see caries like I do in Hamilton." She said, "Well, maybe it's because I give them fluoride tablets." And I said, "I think so." Today, this year earlier, I spent some time in one of the biggest schools in Hamilton. I examined 751 students. The DMF rate averaged between 0 and 1. The number of fillings that I'd have to do in those was under 5%. Very, very different to the days when I first started practice here. And so I have specialised in periodontics, and it's one of the preventive measures of dentistry. So prevention is my interest. Fluoride therefore becomes a natural. In the Kura Kaupapa school that I examined earlier this year, the same is to be found amongst those Māori students as I did in the big Hamilton school, predominantly European. Much the same, you see. There's not a big gap there. Elsewhere in the country, there is a gap. And so one of the things is that the CWF is trying to close that gap between oral health status between Māori and non-Māori. So most dentists, and I myself, support that. General dentistry has not always been pleasant, as I've said. The disparities we have learned. I respect the findings that come out of the University of Otago Dental School, where Professor Dr. John Broughton has done most of the research amongst the Māori in this country. He has researched other areas, a fellow colleague of mine, and the gap is wide. And we need to close that gap between Māori. And so I speak today as a Māori dentist, as a citizen of Hamilton, though I live in 2 places, Kawhia and Hamilton, that we need to preserve the taonga that we have, the health of our children. And so to my Māori people around this area. And I have a lot to do in the social world of Māori, especially in advising or working on some land interests. I am concerned that we need to maintain what we have, that we need to commend those dentists who were so brave in years gone by to make the move to support a move that would cut across their income. How many businesses would do that? They've had to support the social needs of the people more than themselves. So I recommend to the City Council that fluoridation water continue to be supplied. More people will have healthy mouths and gums, better teeth, look better, feel better, and express themselves better because they live in Hamilton and or the wider Waikato area where the water is fluoridated. Do not let the Māori people down. Supply the fluoride to the small communities. I know the clinical benefits, probably better than most. My working dental colleagues and I see it every day. Keep the status quo. No mai, haere mai. Kia kaha, be strong in supporting something that may not always bring pleasure. Kia ora koutou.
Your Worship, councillors, yes, that's me tomorrow. I'm Graham Joel. I'm the senior dentist at Waikato Hospital. That's why I've got the grey hair. Okay, that's my background. And I heard mentioned before previous speakers this morning, I have a military background as well. So I've been over 40 years in dentistry, the last 4 years at Waikato Hospital, private practice all the time before that, and 30 years in the Army. I've seen a lot of changes, and it's been positive. I've seen changes in dentistry like Albert, who I actually worked in the same practice as he did after he was there. I've seen the advancements here in Hamilton and in the Waikato in general. My first years in dentistry did a lot of general anaesthetics. Fortunately, it did get better. We had improvements, and from going from two GA full clearances a day to perhaps 1 or 2 a year, if you were lucky. And that was really a huge change, and fluoride certainly did make a difference. In your own practice, you have patients that are loyal to you, they grow with you, they age with you, and they maintain their teeth like you do. But now I'm back at the hospital, and I'm back at the bottom of the cliff again. So I'm responsible for a lot of the general anaesthetic work that is done there. And so I see children, and they're often the more complex children, special needs people, and people with high medical comorbidities that need dental work that can't be treated outside of the hospital environment. So at the coalface, fluoride has made a difference. I could see it with my own kids. I mean, they don't have fillings, and they've grown up with no fillings, and now they're passing that on to their children. They've been educated here in Hamilton. I'm, by the way, born in Hamilton, educated here, Hamilton Boys High, Moral Intermediate as a foundation pupil, and Hamilton West School, that's going downwards, from primary to secondary. But fluoride is only part of the answer. It's got to be associated with good oral care and diet. Unfortunately, we have members of our community, and you do in Hamilton, have where low socioeconomic groups, and particularly Maori and Pacific Island families, do suffer from tooth decay and oral health care problems. We see it also with recent immigrant groups. People come in, we have a high proportion of immigrants that are coming into this area. So I see children with high levels of tooth decay, pain, infection, and they're in trouble. We also have a responsibility to our special needs groups. So Hospital Dental Service is charged with providing that care for those groups that cannot receive primary health care in the normal community setting because of their complex medical and dental needs. So you have high vulnerable groups with high and complex needs. Unfortunately, Maori are overrepresented in these groups. Higher rates of disability and special needs of all age groups. Nearly half of Maori over 65 or over have a disability and are less likely to have seen a dentist. And they have many complex medical issues. We've heard it before, the high cost of dentistry and low incomes is a major factor in a lot of New Zealanders not accessing regular dental treatment. The problem we have at the hospital is that we have low volumes of high complex needs individuals who require a lot of work and which can't be done elsewhere against the high volumes of the less complex. It's people with toothache out in the community, and we have to have a balance between that. It's interesting study of the definition of high needs and vulnerable populations. You can see New Zealand looks at residential care groups, people with severe disabilities and handicaps, excuse me, severe mental illness, complex needs requiring medical support, children requiring GA, and IHC adults and adolescents requiring general anaesthetics. The other countries have a different spread, and you can look at that for yourself. So involving, this is community oral health children, that's 0 to 17, but we'll take the 0 to 11 age group. You can see at Waikato Hospital, Tikawiti Hospital and Thames, significance 2,400 general anaesthetics for those children in a 3-year period. It's easy to see, blue and purple. Blue being Maori, purple other, and the white is Pacific. It's 50-50. If you take Maori and Pacific Islanders, it's almost 50-50, but it's not 50-50 ratio as far as the ethnic population. The age groups, of course, as they get older, you expect their treatment. If they need treatment, there's more. They've got more teeth, they've had there for a while, they've been exposed to their dietary and all the other issues involved. So I think at the hospital it's something like 650, this is Waikato, for the general anaesthetics that are done. Remember, it's not just children we're doing, we're also treating adults, special needs people, and an increasing group of elderly that cannot access dental treatment in the community environment. So it is a costly business. Theatres cost about $1,000 to $1,200 an hour to run. We grab all the extra time we can to just to try and keep our wait lists to a reasonable level. Okay, there's a young child under general anaesthetic. You can see all those top teeth are just right down to the gum level, and the lower teeth are decayed as well. I'll see a lot of those because I don't see the good ones anymore, I'm seeing all the bad ones. And so that there's a full clearance probably on a 3-year-old. You see some with reasonable teeth, but even that child has still had to have a couple of stainless steel crowns inserted, so there was some decay there to be treated. I used to like it in practice where my patients had good teeth and you just didn't see that. I don't see it now, I'm seeing all the hard stuff. So I've taken full clearance on a 19-month-old child, treated them as young as 11 months. And for some children, it's a sad fact that dental pain and abscesses are a way of life. So regardless of socioeconomical status of vulnerable families, it's not the children's fault. And you must remember that it's the children that are important, it's the patients that are important. So we all share a responsibility for the less fortunate. I say something done for the greater good is something that may not benefit you personally, but may benefit the human race as a whole. And as councillors, and I'm an ex-district councillor of 2 terms, like rates, they may be good for you from an individual point of view, but they are for the greater good of Hamilton City. So I wonder if your ratepayers feel that that's the way it is. The scientist and I agree fluoride does work. There's been heaps of research done on that over the years, and it just seems to be like reinventing the wheel again. Research shows that 0.7 parts per million is totally safe and reduces dental decay significantly and with dental issues. There is a benefit throughout life, and it is particularly useful to our vulnerable populations. I can't believe that it's only $40,000 to fluoridate Hamilton's water supply. Compared with all the other things I see at the hospital and in medicine, it's an absolute drop in the bucket. You as councillors have a responsibility to either support or reject, and I hope you take it seriously because you are affecting the health of the community. I think it's time to stand up and be counted and support a well-researched measure backed by all government health bodies, dental and medical groups, and I think the silent majority of the population. It makes common sense. There are absolute benefits. It does help our most vulnerable, and it certainly helps our Maori population, which has you and the Crown and all of us as New Zealand have responsibilities under the Treaty of Waitangi. So in conclusion, I certainly strongly support you maintaining fluoride in the water supply.
Your Worship, councillors, my name's Rob Aitken. I've been a dentist in Hamilton for about 40 years. I think you can tell from my hairstyle that I'm not actually a recent graduate. I've worked with Community Oral Health Service now since 2008, and it's in that role that I wanted to address the council this morning in support of continued water fluoridation. Just as a very quick background, our Community Oral Health Service has around 63,000 children enrolled between 0 and 17 years of age. That's probably about 2/3 of the actual population of children in our DHB. We've got 110 staff, of which about 100 are dental therapists and assistants. And due to the government's 2011 oral health business case, we now have some beautiful new clinics, which vary between 2 and 6 chair clinics, and we have 15 mobile units that service the entire DHB. And I think sometimes we forget just how big our District Health Board is, and that it takes me just as long to drive from Taumaranui to Whitianga in the north as it does to drive to Wellington. And I'm going to address this issue a little again and when I talk about access to care. Graphs are wonderful, and they're always wonderful when the line points upwards. And this is a graph over the last 7 years, and it's the percentage of children caries-free at examination. And you can see that in our children that are 5 years of age, we have something like 60% that are free of decay at examination. And another good line, heading upwards again, this is our children that at age 12 at examination, 55% are caries-free, which compares very favourably with the picture back in 2005. Well, here's another graph or another diagram, and if you draw a straight line through here, it's not quite so encouraging. And these are the referrals to our hospitals, Waikato, Thames and Te Kuiti, for general anaesthesia. And you can see that last year, 2012, there were some 870 referrals made by me to hospital services from our therapists. Now, in addition to this, Graham John, my colleague, would receive another 200 or 300 referrals from dentists, from doctors, and from public health nurses. So why is this? Why do we have an improving oral health status in our review examinations? And why are the number of general anaesthetics and the serious dental cases increasing? I can show you a good version of the small version you saw earlier this morning. This photograph is typical of those that we see for children undergoing general anaesthesia. And you can see why in medieval times they thought it was a worm that came out at night and ate your teeth. And in medieval times, dental decay was actually a disease of the wealthy, not of the poor. A total reversal to what we have now. So why is that? And I'd like to explain a little bit about the significance of this picture and why it relates to the importance of fluoride in our water. In 1870, the true cause of dental decay was discovered. And this is the 1870s formula. Sugar plus bacteria equals acid. Acid plus tooth equals decay. Simple. So if we could attack any part of this formula on a population basis, if we could attack any part of this formula, we could reduce the incidence of dental decay. The number one problem, it begins and ends with sugar. I don't know whether you saw the program with Jamie Oliver in the United States where 57 tonnes of white sugar were added to the milk for Los Angeles schools each week. I like meat pies, and I was really chuffed the other day when I heard that there's actually more sugar or more calories in a 6-pack of sushi than there is in a meat pie. Why? Because sugar's added to the rice. We add sugar to white bread. As we heard this morning, then in Coca-Cola and other soft drinks, there's 1/3 to 1/2 cup of sugar. Per capita, New Zealanders consume more sugar than Australia, the United States, or Great Britain. So this is our problem, and this is our enemy. So what happens? Well, after you rinse your mouth with a sugar solution, you can see the pH of the saliva drops, and it goes below what we call the critical level, 5.5. And this is where tooth dissolution occurs from the acid generated by the bacteria in the plaque on our teeth. And this effect lasts for several minutes. So the more times you take in a sugary drink, the more you're exposed to decay, and the less clean your teeth are. Obviously, the effect is so much worse. This article then will explain my stance on the importance of water fluoridation, and it will also explain the use of a photograph that you've seen a couple of times already this morning. This is a recent study. It's in the American Journal of Public Health, March 2013, and it's a study of 16,500 children in 4 states of Australia, and it looked at water fluoridation and the association with the consumption of sugar, sweetened beverages and dental caries. And the conclusions of the study found that the consumption of these type of drinks were much higher in the lower socioeconomic groups. They were high in males, they increased with age, and they were also higher in families where the parent had not achieved an intellectual attainment. So we find then that this is now a disease of the poorer communities, not of the rich as it was in medieval times, and sugar is still the main driver of it. The study also found, though, that the increased exposure to fluoridated water actually helped to ameliorate the apparent effect of the sugar sweetened beverages. And so these results underscore the importance of us in our risk assessment of the consumption of sugar drinks that children partake, and also reconfirms the benefits of community water fluoridation in reducing the levels of dental disease. So this graph very quickly shows the DMFT in deciduous teeth, decayed, missing or filled teeth, and it shows that with 1, 2 and 3 drinks, then it rises as it does in the permanent dentition. This is the average sugar sweetened beverage consumption for children between 0 and 7, age 5 to 10 and 11 to 16. And you can see that with a greater than 50% lifetime exposure to fluoridated water, then the decayed, missing or filled tooth surfaces are less. And I heard this morning, we listened to arguments against fluoride in the water, and one of the arguments was, so one tooth surface, what difference does that make? Let's say we have 20,000 children in our population group. Let's say we reduce in our 0 to 5, that's 20,000 children 0 to 5, we reduce the decay on one surface in every child. So over a 5-year time, that's 20,000 fillings or surfaces that need to be treated. Over a 5-year period, if you say that's 4,000 a year, 4,000 surfaces a year, an average filling for a preschool child would take half an hour. So 4,000 lots, that's 2,000 hours. Our current therapists have a 1,400 hour each year chairside. So this is a colossal improvement in terms of resources that could be made available. Thank you. So in our key protective factors in our risk assessment, living in a fluoridated community is the number one. Why? Because all the others depend on interactions between parents and caregivers. All of these depend on us being able to get the child into the clinics for care. And only 2/3 of the children in our DHB, and it's the same here in Hamilton City, can actually access or do actually access the care that's provided. So we have a large number of children between 0 and 5, the key and the most crucial years, that do not access any care. And these are the ones that provide the basis for the dreadful things that Graham has shown you and that we see in dental anaesthesia. So fluoridated water provides a baseline of protection for all children, irrespective of where they live, their socioeconomic status, access to regular care, or to diet. This is my belief. There is currently no scientific research or evidence worldwide that demonstrates fluoride added to drinking water at 0.7 to 1 parts per million poses any health risk. The overwhelming balance of scientific research and evidence worldwide continues to demonstrate fluoride added to drinking water at 0.7 to 1 parts per million has a beneficial effect by reducing the incidence of dental decay. Thank you.
Thank you, Your Worship, Mayor, Councillors. I'm Robin Wyman. I'm a consortium partner with the National Fluoridation Information Service. I'm a general dentist and a specialist have specialist training in dental public health. I, in my day job, am clinical director for oral health services at Hawke's Bay and Wanganui District Health Boards. I've been asked to briefly talk to you about the process of dental decay and just what we're actually talking about in terms of how this actually works. Dental decay occurs on smooth surfaces and the tops of teeth. What we commonly call in the industry pit and fissure caries, or the biting surfaces of back teeth, and the smooth surfaces, the outsides and fronts and backs of teeth. It is in younger children more a decay of back teeth than front teeth, and across the population these days more a disease of back teeth than front teeth, largely because of the beneficial effects of fluoride, which is largely protecting more the smooth surfaces of the teeth. And if you think about it, on a back tooth you've essentially got 5 surfaces, the top, 2 outsides, and the front and the back. And so 4 out of the 5 of those surfaces are helped by the effect of fluoride, with a much smaller effect on the biting surface. As we've talked about, and Rob alluded to, the issue of how does this actually work? Is this what's going on? Basically, the process of decay, once you get the acid forming around the outside of the tooth, is to drag mineral out of the tooth, and that's what the process of decay wants to do. It wants to pull that calcium and phosphate out of the tooth. But fortunately for us, it doesn't pull it out from the very surface first. It actually pulls it out from just underneath the surface, which is that triangle that you can see represented on the diagram up there. And what fluoride does is actually changes the chemical composition of what's going on at that level and changes the balance of the equation to push the mineral back again. It doesn't completely work, and so you can completely overwhelm this if you put enough sugar into the equation, and that's why we do see children and adults with very high levels of dental decay that have overwhelmed the system. But at a day-to-day level for most people, the fluoride is actually helping to tip that balance back in favour of a remineralisation of the tooth. And one of the councillors asked earlier, do we have any common ground between the people who are proponents and perhaps saying we shouldn't have community water fluoridation? We are agreeing that this is a topical effect. This is largely occurring through a topical benefit. And so the question becomes, well, why drink it if it's a surface effect? And I can hear people saying, yes, I agree with that question. Basically, this model's trying to show you as to what's going on when it comes in through the drinking water. So the fluoride is added to the drinking water and comes into the first box there, and there's a layer of saliva sitting around in the mouth. This was represented to you earlier as just being the fluoride bypasses the teeth and goes down into the body. It's much more complicated than that. Sitting over the top of the tooth surface is what you can see called a biofilm or a pellicle, which immediately after you've cleaned your teeth starts to form back onto the teeth again, and that holds fluoride at the level of the tooth surface. You then swallow the fluoride, it comes down into the blood supply. Some of it is actually moved across to bone. We don't disagree on that at all. And some of it will go to soft tissue. A proportion of it you will excrete in the urine, and some of it will come back in your salivary glands and then come back in the saliva and continue to keep a constant level sitting in the mouth. And so basically what we're doing with community water fluoridation is helping to keep that biofilm with a higher level of fluoride sitting there on a day-to-day basis. And one of the other points that was made earlier in the morning was that this is not a constant system. There's no regulatory mechanism to keep it going, and that's also true. Once the community water fluoridation stops, that regulatory system will slow down and basically not continue to work. There won't be fluoride sitting there coming back in the saliva because you haven't taken it in through the community water supply, unless you get it another way. And the other key way is through fluoride toothpastes. And so toothpaste and community water fluoridation work together with one another to keep that biofilm at a level where you've got enough fluoride to tip the balance back in favour of remineralising the teeth. And I guess in finishing I would say it's easy to say, so why don't we just brush our teeth? The last oral health survey told us that the proportion of people who honestly answered the question and said that they brushed their teeth once a day with a fluoridated toothpaste was only around 2/3 of the population. And before you say, well, that's shocking and maybe people should do better, I just leave you with the thought that the last time you went to the doctor and he gave you a prescription for antibiotics, did you take them all on time and finish the prescription? Or do you actually need the benefit of an environment like this, which helps to keep the whole system working better? Thank you.
Good afternoon, Your Worship the Mayor and councillors. My name is Dr. Robin Wyman. I'm here today in my role as Chief Dental Officer for the Ministry of Health. I'm a New Zealand trained and registered dentist, and I hold a PhD in oral microbiology. I have previous experience within the public and the private dental sectors within New Zealand, including working in Gisborne and Wairoa. I also have an in-depth knowledge and understanding of the oral health issues nationally through leading the 2009 New Zealand Oral Health Survey. As part of Council's consultation process on the fluoridation of Hamilton drinking water supplies, I provided advice to the Ministry. I provided advice on behalf of the Ministry of Health on the state of oral health in New Zealand and why the Ministry believes fluoridation remains an important foundation stone that supports government investment of around $216 million annually in oral health. In recommending fluoridation, the Ministry sees its policy as providing opportunities for an evidence-based, safe and cost-effective public health measure to be made available so that communities can enjoy better oral health through prevention and reduction in the burden of tooth decay, irrespective of age, income or education. The Ministry, however, acknowledges that some people hold major concerns about community water fluoridation, and we are here over the next 4 days to enable those concerns to be heard as part of the expectation of public participation in decision-making at local government level. I understand that 2 issues, why does a decision have to be made locally, and community water fluoridation as a form of mass medication, have been raised in submissions. I'm able to offer advice on these topics from a Ministry perspective, and we also have 2 other Ministry officials here today who can provide further advice. Okay. So the Ministry of Health, district health boards and local authorities all have roles to play in supporting the health of New Zealanders. Under the Health Act 1956, the Ministry, DHBs and local authorities all have a duty to improve, promote and protect public health. This includes oral health. In addition to local authorities' duties to improve, promote and protect the public health of their communities through the Health Act, local authorities must also fulfil duties and responsibilities under the Local Government Act 2002. The local government, for example, holds a responsibility for providing safe drinking water, wastewater and sanitary services, and they are also responsible for ensuring community participation in decision-making about water supplies under their control. DHBs are charged with improving, promoting and protecting public health and reducing health disparities, providing health services, including public health services, to their local populations, and are required to work collaboratively with local authorities to provide advice on public health matters. I understand officials from Waikato District Health Board have previously provided advice to Council on community water fluoridation, the oral health status and impact of tooth decay in your community and on local health services. And today we have heard from the Chief Executive, we've heard from Māori clinicians, we have heard from DHB clinicians, working in the front line as to why they believe fluoridation should remain in this community. So the Health Act and the Local Government Act work together to provide a framework of overlapping and complementary responsibilities to promote and protect public health and facilitate community input into decision making. Water fluoridation sits within the framework of these overlapping and complementary responsibilities. While there is no specific legislation requiring councils to fluoridate drinking water, councils are authorised to do so for the benefit of their local population, and this is consistent with their duty to improve, promote and protect public health. Fitting it all together then, the central policy position is clear. Water fluoridation is recommended and to be extended where technically feasible. Decision making, however, sits with local authorities rather than central government to ensure decisions are made locally, the decision is appropriate for that community, and to enable members of the community to be able to participate in the decision making process as we have here today. There's been quite a discussion this morning about is community water fluoridation a form of mass medication. MedSafe within the Ministry of Health is the final arbiter of what is designated and accepted as a medicine or non-medicine based on the Medicines Act 1981. From a technical perspective, the Ministry does not identify fluorides in community drinking water as medicines. While fluoride in certain concentrations and formulations is listed as a medicine in several schedules within the Medicines Act, for example, fluoride varnish for professional application, the concentrations of fluoride in drinking water are well below the threshold for consideration as a medicine, and so would be considered under the control of other public health and water quality legislation. In addition, the Ministry does not consider the addition of substances such as chlorine or fluoride or alum to water to be under the remit of the Medicines Act, but rather under the control of other public health and water quality legislation. Therefore, with respect to the Medicines Act, community water fluoridation is not mass medication. There is also a pragmatic perspective to be had here too. Fluoride and the presence of fluoride or any other element or mineral in an item does not automatically make that item a medicine. Fluoride is found naturally in a great many places, including air, soil, foods, and source drinking waters. The level of fluoride naturally present in the Waikato River is, I understand, between 0.2 to 0.3 parts per million, rising on occasions to 0.6 parts per million. The Ministry also considers that the principal use of water and foodstuffs which contain minerals or fluoride is dietary and not therapeutic. Another example of this need for pragmatism is quinine. This can be a medicinal substance at some concentrations, but the quinine contained in a gin and tonic does not make the G&T a medicine. The same can be said for margarine substitutes that contain plant sterols and claim to lower cholesterol, or high-fibre breads. They are foodstuffs, not medicines. This pragmatic approach to the legislation is clearly what was intended by Parliament. So, we also understand that some people feel that their human rights are denied when the fluoride levels in the water are topped up for oral health reasons. The issue was considered from the human rights angle by the Human Rights Commission in 1980, which came to the view that in all circumstances the question of fluoridation of water supplies by public authorities does not constitute a denial of human rights. In addition, the decision to fluoridate a community water supply is made locally after consultation with the community. Okay. So, from a national perspective, oral health has improved in New Zealand over the last 20 years, but we still have a serious problem with tooth decay across all age groups. My colleagues this morning have talked about the numbers of decayed, missing and filled teeth, that many children are now caries-free, but some children suffer a higher burden of tooth decay. We know from our own National Oral Health Survey, which was a nationally representative sample of New Zealanders, nearly 5,000 New Zealanders, and a statistically very robust survey, that adults and children who live in fluoridated communities in New Zealand have significantly fewer decayed, missing and filled teeth, and consequently better oral health. And water fluoridation gives the significant benefits to the community. The Ministry bases its recommendation for fluoridation on a large body of international evidence, and its recommendation is consistent with those of key health agencies like the World Health Organization, the Centres for Disease Control and Prevention, leading mainstream health, medical and dental bodies internationally and nationally, and other countries we most readily compare ourselves with, such as Australia, United Kingdom, United States and Canada. Now, I've set up here, mentioned about, we also have, Ministry also promotes other behaviours to improve oral health. And these are toothbrushing, dietary advice, in addition to preventive care and treatment, as well as water fluoridation. We can see, though, that despite years of oral health education and promotion of toothbrushing, we still, there's certainly still improvements that need to be made. And the reason that we promote both water fluoridation and toothbrushing is they work hand in hand, as Robin Wyman has just said before. So in recommending the policy, a great deal of monitoring of the international literature occurs both by the Ministry and the National Fluoridation Information Service, a consortium of New Zealand experts in toxicology, water science, public health dentistry, epidemiology and dental public health, experts who we trust every day with our health and our health decisions. To date, the mainstream international view of key health organisations, coupled with the advice we have received from New Zealand experts at NFIS, supports the current ministry policy. Thank you.
Your Worship, the Mayor, Councillors, good afternoon. My name is Chris Noakes. I'm a Senior Scientist with ESR. I hold a PhD in Physical Chemistry. Over the last 2 to 3 decades, my work has been predominantly in water treatment and water quality. ESR is one of the members of the consortium that make up the National Fluoridation Information Service, and I'm talking to you this morning on their behalf. This is a tank of hydrofluorosilicic acid, HFA for short. This is the substance that is used to fluoridate Hamilton's drinking water supply. And as you've already heard, it is a substance produced during the manufacture of superphosphate fertilizer, and it is also corrosive and hazardous. But the thing to remember is that although the substance is added to the water during treatment, it is not present in the water that comes out of your taps. I want to speak briefly on 3 topics this morning. Firstly, on fluoridation chemistry, how it is that HFA is put into the water, yet it's fluoride that appears at your taps. Regulation of fluoridation, what level is acceptable in water, and how is that limit being set? And finally, control of fluoridation, how is it that the water treatment plant controls the level of fluoride in the water to ensure that safe levels are maintained? So I've said that HFA is added to the water, but it disappears. How is that? There are 2 processes that go on when HFA is diluted and added to drinking water. The first, dissociation, results in the HFA falling into a number of pieces. Some of those are fluorosilicates. Now, the fluorosilicates are of no value as far as dental health is concerned. It is the free fluoride ion which needs to be present to react with tooth enamel to strengthen it. However, helpfully, the fluorosilicates react with water itself, and as a result of that reaction, fluoride, which is what we're after, is produced, and some hydrosilica. Now, hydrosilica occurs naturally to some extent. It's non-toxic and is in fact used as an anti-caking agent in some foods. So the overall process, and it's simplified, this morning it was mentioned that the system is complex and is not fully understood, and that is true. There was a very extensive review carried out in 2002 which acknowledged the fact that there was more information required to fully understand what is going on. But there was sufficient information available then for the authors to make a categoric statement that as far as HFA was concerned and the hexafluorosilicate ion, that its concentrations were 0 to all intents and purposes. So the overall consequence of these 2 processes is that HFA is removed from the water and fluoride is introduced into it. Now, there's often concern expressed that the fluoride which is added to water is different from the fluoride which is present naturally. And the answer is that there is only one type of fluoride. Its properties are determined by its atomic structure, not by what substances it is derived from. HFA, in addition to HFA, there's sodium hexafluorosilicate and sodium fluoride are used to fluoridate drinking water. They, like HFA, undergo dissociation, and in the case of the fluorosilicate, also hydrolysis to release fluoride into the water. Fluoride, which occurs naturally in water, is also derived from the dissolution of one or more substances, but generally we won't know what those substances are. The key thing is that in all these cases, the fluoride that is released into the water has the same atomic structure and the same properties. So there are a number of ways in which we can introduce fluoride into the water, and it may be present for natural as it occurs naturally. The question is what levels are required to be maintained in the water and how are those levels set. The drinking water standards for New Zealand established concentrations which are considered safe for a lifetime's consumption of a chemical. They are referred to as maximum acceptable values, MAVs. The MAV relates to chronic exposure to a chemical, that is a lifetime's exposure, so that slight exposure to small increases in concentration beyond the MAV are not a concern or a harm to health. The MAV for fluoride is 1.5 milligrams per litre. That value is set as taken from the World Health Organization guidelines. These guidelines are produced by an international panel of toxicologists and they are periodically reviewed. The last review for the fluoride guideline was to inform the 2011 fourth edition of the guideline, so it has relatively recently been reviewed. The guideline is set on the basis of information derived from epidemiological studies looking at long-term exposure to fluoride in humans. The guidelines state that in general, in temperate climates, dental fluorosis does not occur or is not observed in fluoride concentrations below a concentration of about 1.5 to 2 milligrams per litre. However, that in situations where the concentration of fluoride exceeds that range, there is an increasing risk of dental fluorosis. The guideline also states that in situations in which the ingestion of fluoride is elevated through routes other than drinking water, that dental fluorosis may also occur at concentrations below 1.5 milligrams per litre. So just to be clear, the MAV of 1.5 milligrams per litre is not the fluoride concentration that should appear in fluoridated waters. The concentration that should appear in fluoridated waters is within the recommendation, within the range recommended by the Ministry of Health, which, as you've already heard, is 0.7 to 1 milligrams per litre. So it is the the fluoride which is added to a water supply is added to top up the fluoride already present in the water as a result of natural processes. And you've also heard that that concentration in Hamilton is of the order of 0.2 to 0.3 milligrams per litre. And the additional fluoride then brings the concentration up to somewhere within the concentration range of 0.7 to 1 milligram per litre. It is the responsibility, therefore, of the treatment plant supervisor to ensure that sufficient fluoride is added to the water to bring it within the concentration range important for dental health, but not so much fluoride is added to exceed this value, which is relating to the protection of overall health. So briefly, the way the fluoride concentration is maintained and controlled in Hamilton is the water is abstracted from the river, it goes through a series of treatment processes. The water is then held in the contact tank for a time to allow disinfection processes to complete, and then it is reticulated to the city. Near the end of the treatment process train, HFA is added to the water, and that concentration is monitored continuously as a control process. In the event that the concentration drops below 0.3 milligrams per litre or exceeds 1 milligram per litre, the control unit triggers an alarm which notifies the treatment plant operator and also shuts down the dosing pump of the fluoride if the concentration is getting too high. There is also a second check on the fluoride concentration in the water leaving the contact tank, so that overall there are two continuous checks on the fluoride concentration in Hamilton's drinking water. And just to summarise, HFA is certainly a hazardous substance, but when it's added to water, it reacts, disappears, and is converted to fluoride. No matter what the source of the fluoride is, the fluoride ion is the same. It is not chemically different natural fluoride from additionally intentionally added fluoride. The MAV for fluoride is 1.5 milligrams per litre, which is intended to protect health overall, but for dental benefits, the concentration needs to be between about 0.7 and 1. And finally, Hamilton's water treatment plant has continuous monitoring to ensure that the concentration leaving the plant and entering the city is maintained at an acceptable concentration. Thank you.
Good morning, Your Worship, and councillors and colleagues, and the public of Hamilton. I'm Dr. Pat Tui. I'm a paediatrician and the Chief Advisor in Child and Youth Health at the Ministry of Health in Wellington. I'm convinced from my own study of the existing evidence that fluoride in our drinking water is safe at the levels we allow in New Zealand and effective at reducing tooth decay. It has an important role in the promotion of good dental health alongside a healthy diet, good dental hygiene, and the use of fluoride toothpaste in regular dental checkups. However, the debate today is not just about science. The science is important, but as we've seen in the submissions to the Council, this debate is also about personal beliefs, moral values and legitimacy. But let's start with the science. While ongoing research is important, we have to make decisions in light of current knowledge. So how do we judge the scientific literature? Published articles in peer-reviewed journals are the best approach we currently have to ensure that errors and misinterpretation of experimental and observational results are identified and corrected. The scientific literature also builds up in a critical mass in which research findings tend to converge on a consensus. However, there's always papers which find results which are different to the mainstream. Usually the differences are explainable, such as due to bias or bad experimental design. However, we need to keep an open mind. And the point here is that you can always find another paper, and you add papers to one side or the other of the equation, and eventually the seesaw breaks. The analogy of that is communication has broken down. With respect to fluoride in drinking water, the research shows that it's safe. Some children drinking fluoridated water will still get tooth decay, and some may have mild dental fluorosis. But the evidence that a wide range of adverse effects is associated with fluoride at below 1 part per million is just not there. However, the debate and the presentation of papers which support one view or the other does tend to raise uncertainty in the mind of the public and others. There are a range of concerns that people have about fluoride in drinking water. We don't have time to cover every single one today, especially given that most of them are theoretical rather than have any evidence behind them at all. But two that really do cause some public anxiety are cancer and brain damage, which is portrayed as a lower IQ. So I'm going to take a moment just to look at these. Around the world, bone cancer is a relatively rare disease. There are many different sorts of bone cancers, which new techniques have distinguished from each other. Ionizing radiation is a proven cause of bone cancer, and these cancers sometimes affect children who have been cured of an earlier cancer with radiotherapy. But for many cancers, the causes are obscure and unknown, except for some very rare cancers. The cancer does not usually reveal its cause. There are risk factors for cancers, but it's impossible to definitively prove that any particular osteosarcoma is associated with a particular cause, such as fluoride. We now have sophisticated cancer registries and a better diagnostic labelling. A number of studies have been done on these registries which have looked at osteosarcoma rates both over time, which is, as I have there from one of the New Zealand cancer registries, and within fluoridated and non-fluoridated areas. New Zealand data, and again and again, no changes, and there is no significant difference between fluoridated and non-fluoridated areas over time with sophisticated and accurate cancer registries, which are now more accurate than they've ever been. And New Zealand data shows that for the children and adolescents, the rate of bone cancer is no worse than it was over the whole period of 50 to 60 years of fluoridation. What about IQ? I'm aware of a number of studies which have suggested that very high fluoride levels can lower children's IQ. These studies I do not believe are relevant to New Zealand because they use invariably as their baseline, in other words, the level at which no effect is seen, to compare against high levels of fluoride, the sort of levels that we see in our own drinking water, where it's fluoridated. They're not all robust studies, and some have serious problems. Now, some of you may have heard of Professor Jim Flynn, internationally published philosopher based at Otago University. Over the years, he has identified that the IQ of children around the world has risen significantly. He identified this as a real increase. It's not a measuring error. And the causes seem to be related to better nutrition and a wider range of social experiences. And this has all happened with over 50 years of fluoride in our water, over which time the IQ of children in New Zealand has risen by about 12 IQ points. When you look at what the possible causes of changes in IQ are in children, there are huge socio-cultural effects. As a paediatrician, I see a range of issues that might affect children at an individual level, particularly malnutrition. Clearly lead, as was identified, as a neurotoxin, and it's important to get that out of our environment. Alcohol is probably, however, one of the most serious neurotoxins in our environment when it comes to children and acts prenatally. When you look at these threats to the IQ of our children, and we do see them occurring, fluoride is not even in the ballpark. So how do we decide? The evidence indicates that fluoride in drinking water has a low risk for adverse effects, and that's mild dental fluorosis, but a high level of public concern. Now, we all live with risk. Some of us are more risk tolerant than others. We manage it every day, and by and large, we manage the risks that we see pretty well. On the Ministry of Health website, some of you who have been there to look at the fluoride may have seen this paper, which identifies an issue called outrage. And outrage is a term identified by Peter Sandman for the emotional response that we have to a hazard. And a hazard, as a perceived hazard, is something that we see in our environment which concerns us. And it's very important to realise that these are linked components. And the factors which determine, if you like, our outrage factors relate to that particular list which was identified by Sandman many years ago now. So these relate to things that we might consider safe, are things that are more voluntary, natural, familiar, not memorable. I could go on. Now let's have a look at whether fluoride ticks our outrage boxes. I think Sandman has identified the factors that when you are dealing with a low hazard but high outrage factor, this is the sort of response you get. So how should we respond? Sandman says, if you have a low hazard, high outrage factor, it's a waste of time dealing with the hazard. Deal with the outrage. That is what is causing your public concern. It should be very clear to you by now, from the evidence that's been presented, that fluoride is a low hazard issue, but a high outrage issue. So how can you, as a council, deal with this? Well, it's important not to assume that people are overreacting. There may be some people who are naturally more cautious than others, and we know, and they're more likely to invoke, if you like, the precautionary principle. For some people, safe is better than sorry, and this has to be respected. But it must be acknowledged that this is a personal position for people, and it doesn't necessarily drive public policy. So how do we address public concern? People value the right to make choices in matters that concern them, and they should be given this right, and this is why we believe that this is a local issue. However, often around the country and around the world, the decision on whether fluoride is added to drinking water is made by decision-making tools such as referenda. And in my view, referenda are appallingly bad processes for doing this because they are so easily hijacked by those who have a particular view, either for or against. And the people for whom actually fluoride is a non-issue don't have a voice. They lose their voice. So therefore the democratic issue is undermined. And a better way of doing it, in my opinion, is to do what the Council has already done on a couple of occasions and what the Ministry of Health done, is to undertake survey-based approaches which actually give every person in the community a voice, so the democratic process is upheld. Lack of choice is also an issue, and I don't know if it's a possibility here, but I come from Lower Hutt in Wellington, and in Lower Hutt the Council has made available water from a natural aquifer which is closely monitored, but it's not fluoridated or chlorinated. If that was possible here, then a lot of the people for whom choice was one of the big issues, and we see for the submissions that lack of choice is a big issue for people, not the science, but the choice, then that might be one way of identifying whether the Council could address that particular outrage factor. Another issue which has just been spoken so well by my colleague is the issue of, is our water free of toxic chemicals? This is often an issue which is raised, and I would recommend things like regularly publishing the monitoring reports, the analysis of the fluoride. Make it known to people. Make it know that you actually care enough about this material that is going into water that you will let them know regularly how often and how much it is. And finally, I'll talk about trust. The health professionals here are the same ones you trust to promote the oral health of your families, keep your drinking water free of E. coli and your restaurants free of cockroaches and rats. They also help to protect New Zealanders from the SARS and swine flu pandemics which we've experienced over the last decade. You trust them to do their jobs, and they've done them well. Doesn't it make sense, therefore, that they're not getting the science wrong about fluoride? It's almost unthinkable that they would deliberately mislead the public in this way. They are doing a good job. You trust them to do that. Trust them on this. But trust has to be earned, and I believe that they have earned that trust. So, in summary, fluoride in our drinking water raises strong emotions, but the science is very clear. It is safe and effective. Most people are okay with fluoride in their water, and multiple surveys have shown this. If you monitor it properly and show them that it's doing good, most people would be very happy to continue with fluoride in your drinking water. Thank you for the opportunity to speak to you.
Your Worship, Councillors, we're in a bit of a quandary as to who should be presenting to you today and who should be in this group today, because a number of you have heard me present on this topic on several occasions over the last 10 years. So although we've ended up with quite a busy presentation with multiple people coming up to speak to you, firstly it gives you some fresh faces, but more importantly I believe this reflects the breadth and the depth of the support for water fluoridation. The vast majority of doctors and dentists and health professionals support fluoridation. And when we talked about what do we have in common between those who are opposed and those in support, the other thing is that in addition to promoting fluoridation, we also are very keen for people to be educated and understand the importance of good oral hygiene, and that they have a very good diet and they have regular health checks to keep themselves healthy. That prevention is what we're after rather than cure. Because of the multitude of the vast majority, we have some people that will represent us either as organisations or as leaders in their field, and we hope that's been a reflection of what you've seen today. What we do know, however, when it comes to getting people to change their diet or their personal behaviour, that it's exceedingly difficult. If we get to that point where we're not seeing any benefit or change in due to the fluoridation of our drinking water, we would not need to promote fluoridation anymore. However, currently, when you look at our New Zealand dental statistics, we are still seeing that while oral health is improving, we have graphs like this that show there is still, over time, a benefit from having fluoridated drinking water. and even those who have opposed have mentioned that there is a benefit, there is a health benefit, and at a population level that is particularly significant. And not just in terms of cost. Craig's mentioned the impact this could have on the DHB in terms of treatment, but it's also about the cost of pain and suffering for children and adults who have avoidable dental cavities, and that's what we'd like to see reduced to that degree. So while we have the benefit shown like this, and we have no evidence of harm, and we have community support, then we will be continuing to promote fluoridation until that time it's no longer present. So what we'd like to do now is be available for your questions, and any members of the group are here to respond to any queries you may have, so we can help assist you in making your decision.
Thank you very much for that presentation. So now I'm going to go to questions, Councillor. So we have 30 minutes allocated for questions. So I've got the Deputy Mayor first.
Yes, thank you. Look, the group this morning presenting talked about the need for more science. And I know we had the comment about this paper equals that paper and the balance and so on, but I'm just wondering if one of the group could answer that question about what more science would be about. Is there more science coming? So that's number one. The second question, and again you can decide who answers it, I'm just interested to know about the European community, because it seems there's a big block of those countries that don't fluoridate against the United States, Canada, Australia and New Zealand. So I'm wondering if someone could give me a little bit of a fit on what the difference is in thinking between those two different blocks, the European bloc and, well, for want of a better word, an English-speaking bloc. I don't have the answer to that, but I'd just be interested to know how that sort of shapes up.
Right, so two questions there. First one, is there more science?
Well, in terms of the science, the National Fluoridation Information Service has an ongoing role to monitor the literature that's coming through. We do that by virtue of monitoring the papers that are published every 6 months, and there's a publication put on the website reviewing those. I think there are two areas that I would look at as being core. One would be we need to continue to make sure it's actually having benefit. I think the valid point is that if water fluoridation is no longer getting the benefit we think it's getting for dental health, then you wouldn't continue to do it. The evidence continues to show it is, but that needs to be continued to be monitored if you're going to put the policy in place. The second is to make sure that these continuing questions about health effects are looked at, but the point was made that this is expensive, difficult research to do, and you've got to look at the potential benefit, and that's another critical process that goes through a funding agency point of view to look at whether or not this research actually has got enough valid points in it to make this research worth doing. But the Fluoridation Information Service has the fundamental responsibility of monitoring that research and then making a recommendation to the Ministry every 6 months about whether or not the community water fluoridation policy continues to be appropriate.
So in terms of the funding, sorry if I can just ask an additional question on that. I mean, I don't know what expensive is. Is it some millions of dollars?
Some of these
has
studies,
New Zealand funded, the Ministry funded, apart from the other normal studies, significant research on it?
the Ministry has, the funding community in New Zealand, there is a Dental Research Foundation fund as well, which tends to fund smaller projects. Certainly there's been funding given to ongoing monitoring of the oral health effects in New Zealand, and the other area where there's been quite a lot of research done in the last decade or so would be on the fluorosis levels in New Zealand to monitor whether we're getting that known adverse effect. On the other wider health questions, we do tend to rely on wider studies from the rest of the world, largely because you're needing big population groups and bigger funding amounts to be in place to do the studies in a valid way.
Okay. So second question was the European, or Europe. Yeah.
I mean, I think when you look at the socio-political situations that sit behind water fluoridation as a policy, you are dealing with a lot of history. So when you look at Europe, yes, it's true to say that a lot of continental Europe doesn't use water fluoridation as its core policy for providing fluorides to its population, but it's completely incorrect to say they don't use fluorides as a way to control dental caries in that context. Mention was made of salt fluoridation. There's widespread use of toothpaste fluoridation, and toothpaste fluoride levels tend to be higher in continental Europe. If you look to Ireland, which is part of the European group, not continental Europe, that's got, the Republic of Ireland has got nearly 70% water fluoridation coverage. So it's very socio-politically driven. There are some issues around the way that water supplies were designed, and you're talking about some old cities there as well. But it's a complex mixture of old cities' water supply designs and socio-political situations and other political decisions that have been made around how to deliver population fluorides. But I would venture to suggest that all those populations would follow WHO advice, which is that a population fluoride strategy needs to be in place to control dental caries. It's just a choice about which way you do it.
So if it's having that success in Australia and New Zealand, you think some of those European countries would want to pick it up and run with it?
I think you're talking about long-running policies that are in place, and one of the things to also bear in mind is that the general advice is not to mix your population strategy. So toothpaste and water, or toothpaste and salt, but you don't start mixing salt and water together, because you start to get into difficulties with total population consumption. So if you've already got a population strategy of one of those in place, you're almost certainly not going to go down the track of another one, a different one to those.
Okay, thank you.
Okay. Right, any other questions, councillors? Yes, Councillor Leary.
Thank you. Thank you for your presentation. Just one clarification before a couple of questions. I think I heard someone say that they agreed that fluoride in the water can cause some dental fluorosis. That was correct, wasn't it? Yeah, I did hear that right.
Almost everybody would have said that.
Okay, thank you. So question, there's obviously strong opinion out there, and we heard this morning that fluoride is the most effective, and some say the only effective when applied topically. Rob Aitken, you said that you agreed with that unless you can get it in another way. Has the DHB considered other ways to deliver fluoride?
Yes, of course. Thank you for the question. We're looking at fluoride varnish strategies. We're looking at toothbrushing campaigns. The one thing that we face in all of these is access to the children and resources. As I pointed out before, we have a staff of 95 therapists and assistants that cover the entire DHB. So I heard this morning, again, there was a very successful pilot study on toothbrushing in schools. And Scotland has a very successful health strategy for oral health, where they provide supervised toothbrushing twice a day. And the key is supervised, and the key is the resources to actually achieve that. And so against that background of the population that we're dealing with, the area of our DHB and access to care, then water fluoridation is the easiest and most cost-effective way and the safest way to reduce dental caries.
Could I also add to that? In my role as the Chief Advisor at the Ministry of Health and Child Health, I'm responsible for the clinical oversight of the Well Child Program. And here in the Waikato, around the country, we have a thing called the Before School Check, which was actually built off a Waikato initiative called Fit for School. As part of that, Plunkett nurses and Tamariki well child nurses around the country are being provided with toothbrushes and toothpaste for 4-year-old children to be able to give them as part of this 4-year-old check. And increasingly it's becoming an important part of actually getting the message around oral health. We also measure with a new program called Lift the Lip, which is a program that a well child, Plunkett nurse, Tamariki nurse, actually actively looks at the tooth surfaces of children as part of the Well Child program from 9 months right into 4 years to identify dental caries early and to make sure that they are linked in to the community child health services.
Great, thank you very much. Just one last question. Obviously, and it's been in all of the presentations before you as well as in your group, around children and the increase of children drinking these sugary drinks. So I guess kids don't take a glass of Coke and swill it around their mouth and then swallow it, and yet the damage of these sugary drinks is evident in the evidence of the kids' teeth. So I'm thinking that that's just a passing over of sugary drinks, and that's quite a substantial destruction of teeth. So then are you saying, putting the topical issue aside, that the same passing over of a glass of water with fluoride in it can help mitigate those kinds of destruction in teeth? Did I make myself clear?
It probably goes back to the rather complex diagram at the end, which is that once, if you take a drink of fluoride, of fluoridated water, some of that fluoride will be bound up onto the surface of the teeth by virtue of this biofilm or pellicle which lays on the surface of the teeth, which is a soft tissue, which is a soft build-up. And then some of it comes back through in the saliva and tries to keep you at a constant level. Going to the sugary drinks, the same process tends to occur. It seems easy that they've swilled the stuff and taken it past their teeth and it's gone down into their tummy and gone past the problem area. But in fact, well, there's a couple of issues. One is that the behaviour is not quite as simple as that. Swilling and holding it in your mouth is sometimes part of the deal because of the acid taste. But the other part of the problem is this biofilm again. It holds the sugar, and then you get this dental decay problem arising. So if you do it frequently enough, and as Rob showed with his graph, you get this acid forming frequently enough, then you'll start to get decay. If you do it a couple of times a day, you'll probably be absolutely fine. If you keep doing it and keep doing it, keep doing it, then we get the dental decay problem.
Thank you. Just one last quick question. Is the concentration of fluoride higher in toothpaste if you brushed twice a day than it would be if you drink the recommended amount of 8 glasses of water?
Yes, it will, because most of the toothpastes that are available on the shelf have between 1,000 and 1,500 parts per million of toothpaste in them. So the concentration is higher. The dose may be slightly lower depending on how much toothpaste you use.
Yeah, thank you. Thank you.
Okay, I've got Councillor Hennebreth and Councillor Boss.
Yeah. Question to Chris Noakes. You did show us with your little diagram, I believe, that fluoride does get into soft tissue and bone, so it was recognised that happened. Is there any studies as to whether that actually can damage that tissue or bone?
Are you sure that was...
Was that yourself?
No.
Oh, I'm sorry. Sorry, yes. I wrote my question down here.
Well, that's the ongoing studies. At the level of community water fluoridation, the information that we have is no, that doesn't cause a problem. At higher than community water fluoridation levels, then yes, there are problems. And one of the acknowledged problems is skeletal fluorosis. If you are talking about 4, 5, 10 parts per million fluoride in the water supply, which in some parts of India and China where there's endemic fluorosis present, you will see those conditions presenting. But no,
so
the contemporary evidence...
That's your teeth, isn't it, that you're talking about?
Sorry?
That's the condition of your teeth you're talking about.
No, skeletal fluorosis is a condition of your bone.
Bone.
Okay. But no, at the level of community water fluoridation, the evidence is that there are not other ongoing health problems. At higher levels of fluoride, yes, it can get into those tissues and cause other problems.
So a young child who's brushing twice a day or 3 times a day like my kids used to, and not supervising it, could have swallowed an awful lot of fluoride. What could happen?
The first problem we tend to see is the issue of dental fluorosis, and that is well known with swallowing large quantities or eating toothpaste, and that's why you will see on the tubes, don't eat it, don't swallow it. Dental fluorosis is the most common effect when you look in fluorosis studies and go back on the fluoride histories of those children, is actually their exposure to swallowed toothpaste rather than community water fluoridation.
Thank you.
Okay, Councillor Boss.
One question is, in the medical profession, where is the World Health Organization held? Who are they, and how does the medical profession look at them as a body?
All right, thank you. The World Health Organization is an international body which has representatives from most countries around the world, whose role it is to identify and public health issues and to promote public health interventions for the good of international communities. So they are what you might call a peak body for public health. They are not a legislative body. They rely on consensus to achieve recommendations to their member states, a bit like the United Nations for Health.
Thank you.
Yeah.
And the second question I have, at the levels of fluoride in our water, in our drinking water, has anybody, any medical professional or anybody ever proved that it was the cause of sickness or death at the levels of that it goes into our water at the moment?
Well, certainly I'm not aware of any research which has proven that a particular illness in an individual was caused by fluoride at the levels in our drinking water. Certainly you can be poisoned by fluoride at extremely high levels, as everyone has pointed out, but at a level of 0.7 to 1 part per million, it would be impossible to say that this particular cancer or that particular thyroid problem was actually caused by fluoride, because it doesn't leave fingerprints behind, if you like. There's no, you can identify risk factors, but actually, how do you tell? That's my my understanding of the literature at this stage.
Thank you.
Councillor Forsyth?
I've got a number of questions, but I'll try and prioritise them. I'm sort of thinking about the legislative framework that we have to operate under, and one of your presenters referred to the Health Act and the Local Government Act, and I know the Treaty of Waitangi was mentioned as well. Given that the treaties are Crown Māori Partnership Agreement, what role does Hamilton City Council have in delivering those deliverables? So that's my first question. Secondly, the Local Government Act 2002 has been referred to, but I mean, the Act has changed for us. We're now operating under 2012 legislation, which talks about how councils are obliged now to deliver most cost-effectively core infrastructure. So where does putting fluoride into our water system sit in that? And thirdly, if this is such a heavyweight topic, fluoride, delivery, and actually water and fluoride to me are quite two different issues. Get the fluoride thing, but I'm not sure about the water delivery part. But if we go back to the absolute importance of this issue, why has it been, this responsibility been devolved or passed on to local government? A lot of questions there, but if you could answer them, I'd be really grateful.
Hi, thank you. Phil Knight, Chief Legal Advisor at the Ministry of Health. I'll try and respond to those in reverse order. So the first, if I take the final question there, why is this a matter that sits with local communities to decide? This really comes back to the key point of choice that's been made in a number of presentations today by these speakers, which is recognising in terms of, from a democratic point of view, in terms of having the ability for decisions around fluoridation to be made at a local community level for the local population, really gives a better voice effectively for those local concerns to be taken into account, for councillors such as yourself to be party to those decisions and decide what's appropriate at a local community level, rather than having a national policy imposed from on high, with, often limited opportunities for community voice in the development of that. Working backwards, the second question you had was about the changes to the Local Government Act, and in terms of particularly the 2012 reforms, and if I recall, do they make a significant difference here to the obligations of the local authorities? In this case, they don't make a substantial difference in terms of basically the core principles of the local communities for dealing with local issues and thinking about the public health of their population is retained. Now, while there is regard that is given to the cost effectiveness of policies, that also works in combination with the responsibilities under the Health Act for having regard to the health issues for the local population. And I mean, the thing about cost effectiveness in terms of, one, there's a bit of a balancing act that's involved with that, but two, in terms of you obviously have broader concerns for your local population rather than purely cost issues. And what's considered here is in terms of the wider health benefits for your community. Now, the final issue, I should say the first question that you asked was in relation to the role of the treaty and the role of the treaty as it informs local community decisions. Now, the key thing around the treaty is in terms of, look, it has an overlay in terms of effectively all decision making in New Zealand, in terms of having specific regard in terms of the effective decisions on the Maori population, and also the opportunity for Maori to be consulted in and have the opportunity to participate in the decision-making process. And again, that is another key benefit of decisions being made at local levels in terms of to allow the voice of local iwi and whānau to be involved and to contribute to the decisions that are made.
There was just that one other issue too. I mean, what's the issue here? Is it the fluoride or is it the water? In other words, if it's fluoride, can that be delivered in another way other than water?
Well, as a number of speakers have talked about today, is in terms of that this is part of it, you know, basically the public health strategy you use for providing, you know, fluoride, which is a supplement. And in terms of, as the speakers have talked about here, there's different ways that it can be done, but in terms of it needs to be done as part of a strategy that has regard to in terms of broader public health strategies. And if I go right back to the start, if I think to Rudy's presentation right at the start, which was in terms of the whare and the four corners, is in terms of any public health strategy, it's having regard for really in terms of how those four elements, how does the public health strategy work within that. And in terms of for certainly the national guidance is that fluoridated water you know, supplies work best in terms of informing the overall public health strategy to improve basically dental care.
Okay, Councillor Bell.
Thank you. I think one of the presenters said that only 2/3 of Waikato children access dental care.
Yes, that was me.
Could you expand on the reasons for that, please?
Certainly. There's belief that the increasing general anaesthetic statistics are actually drawn from a population base that are increasingly deprived, and many of these people can't travel, won't travel, and therefore, despite our best efforts and our best resources that we have, including a preschool coordinator and an adolescent coordinator, those positions have been set up in the last 2 years within our community oral health service, specifically to encourage the enrolment of children into our services. But there are still some of those outside, especially in lower socioeconomic areas, especially in some rural areas, that cannot access care. So there's a disparity between the number of children that we have in our population and the ones we can actually get enrolled within our service.
Thank you. So would our figures for Hamilton be better than the wider area?
In terms of the referrals from, we have 3 teams in our community oral health service, not surprisingly called Southern, Central and Northern, and Central deals with the Hamilton area. And so out of the 870 odd referrals to community oral health service, just under 300 were from the Hamilton area, so it's roughly a third. We have 29,000 children in the Hamilton area between 0 and 17, and 9,000 of those are between 0 and 5 years of age. So again, I think the population statistics would show around 12,000 between 0 and 5. So again, there are 3,000 children in this Hamilton area that we still cannot get to access care. Although that's not a challenge that we necessarily are just swerving away from, but it's something that requires resources and time, particularly when we're dealing with preschool centres that spring up 1 month and disappear the next. And that's extremely difficult for us to have a coordinated program or strategy to reach these children. If we had enrolment, as there are, I believe, in 6 district health boards throughout New Zealand, if we had enrolment of every child when it's born into every service, then we would have a wonderful start point.
Thank you. An earlier submitter spoke about what they considered the risks to be for bottle-fed infants drinking fluoridated water. Do you have any comments on that concern?
No. Would anybody else like to jump into that one? Pat?
As you would have heard during that presentation, this wide range of what's considered to be upper limits for fluoride intake by children. The Ministry of Health's view is that babies should be breastfed as long as possible, and certainly exclusively breastfed until 6 months. However, we recognise that a significant proportion of children will be bottle fed with formula. The major or the only risk that I am aware of with respect to exposure to higher levels of fluoride intake in the first 6 months of life relate to dental fluorosis, which is almost always mild. And I think the previous speaker was also talking about exposure to or supplements of fluoride rather than fluoride in water. However, I think it's also important to point out that while breast milk has very low levels of fluoride in, breast milk also has very low levels of other items in it which are important for health. And one of them, for example, is vitamin K. And vitamin K is a naturally occurring substance which is not secreted strongly into breast milk, but without it there are babies at a high risk of a disease called hemorrhagic disease of the newborn, which can lead to uncontrolled bleeding and sometimes brain damage and death. And that's why babies at birth are offered vitamin K to get them through the period of time when they until they are on solids or cow's milk. So while it's important to recognise that breast milk is an extremely natural and obviously appropriate food for babies, and we should be supporting it, you can't always guarantee that the components of it are going to be present in the right amount. There is one other point I'd make, which is that with respect to fluoride in infant formula, the lack of breast milk and the consequence with regard to obesity, diabetes, and probably a range of other diseases in adulthood are much more strongly related to the absence of breast milk or the presence of formula than the issue of fluoride. So we know that babies who are breastfed have a higher IQ, they have a much lower rate of obesity and diabetes in adulthood, and that's directly related to the breast milk, and it is absent or reduced rather in babies who are fed infant formula, and that is a much greater risk of that infant formula has, or the absence of breast milk has, than fluoride, according to our current knowledge.
Thank you, and I'd just be glad of a comment if Council were to reduce the upper limit for fluoride, say to 0.7 as happened elsewhere. Any comments around the effect of that?
I don't know. I noticed on the monitoring reports that...
Is that the time?
Okay.
Yes. Okay, Councillor, so we did allow the half hour for questions, but if you do have some other questions that will help you with your decision making, I'm sure you can ask those directly of the people. Yes, no, well, we'd agreed on the time and we had set that ourselves as a council, so sorry people, but we do want to keep strictly to the time frames. So what we're going to do now is, first of all, thank you very much for your presentation, all the effort that everyone's gone to with that, and for those people that have travelled to be here today, thank you for taking that time and effort to be with us today with your presentation. And now, councillors, we're going to break for lunch, and I think we're back at 2 o'clock in here. Okay, thank you very much.